that you don't understand. Now let me ask you all again. You all have done one surgical appointment, am I right?
Yes, sir, we have done.
Okay, good. Right, so some of you all would probably have seen patients with intestinal obstruction during your appointments. But what's important is for us to know also what the different types of obstruction and the basics of it. So let's move on. Okay, right. So what do we want to do over the next few minutes or half an hour or so? I want you to understand what the clinical features of intestinal obstruction are. Okay, it's primarily a clinical diagnosis, so we want you to know what the clinical features are. Also understand the different, when you're doing your clinicals, you will hear people talk about different types of obstruction. They might classify intestinal obstruction in various ways to have a basic understanding of that. And how you use the clinical presentation of a patient and their imaging to differentiate between the different causes and sites of intestinal obstruction, to be able to identify the complications of intestinal obstruction. So you need to have the basic competency to be able to pick up complications and pick them up early. And as first contact care doctors, you should be able to at least initially manage a patient who has got intestinal obstruction. As a house officer, you will be the first person who will see these patients, and you'll need to start the basic care. But what is also very important for you all is to be able to relate your clinical knowledge about intestinal obstruction to your basic science principles in anatomy, physiology, and pathology, because then you will understand why and what is going on rather than just letting it be sort of part of memory. Okay, so we'll try and touch a bit on our basic sciences as well as we go along. Okay, so I'm sure you're all aware that the key clinical features, the cardinal clinical features of intestinal obstruction are these four. That's pain, of course it's abdominal pain, abdominal distension, vomiting, and constipation. So these are the cardinal clinical features of intestinal obstruction. So let's have a little look at each of these in turn. The type of pain that we characteristically talk about in intestinal obstruction is a colic. Can somebody tell me what a colic is? What do you understand by the term colic? If you say somebody has a colicky pain, what does that mean? Let me ask somebody, since nobody is answering. 1133 Dilshan, K-A-G-G. Dilshani, what's a colic? What do you understand by the term colic?
Pain due to a forceful contraction.
Okay, so the reason for a colic is this is bowel, intestine and smooth muscle spasm. But how would you describe, how would a patient describe a colic? What is it like?
A rhythmical tidal pain.
Yes, Ishan. So if you have a graph on the x-axis, y-axis, you have pain intensity from 0 to 10, and on the y-axis you have time. How would you describe a colic? What you said is sort of right, yes.
Like a sine curve.
Yes, so there are what you call peaks and troughs. So when the bowel goes into spasm, you have a severe amount of pain. So the pain intensity goes up, let's say to 8, 9, 10, and it drops down to baseline in between these spasms of pain. And that's typically what we call a colic. This colicky pain occurs in what type of structures? Let's ask 1, 2, 5, 6, Senaratna.
Yes, sir.
So Senaratna, we've described a colic, right? Pain that comes on and goes off, comes on and goes off. It's like spasm. A lot of you would have experienced colics. I'm very sure none of you have not experienced a colic after you've eaten something not very nice and you had a gastroenteritis or something. All of you would have had a colic, so you know what a colic is like. So, what are the structures that give rise to this kind of colicky pain?
Bowel.
Very good. Bowel. Anything else? What kind of a structure is bowel?
Hollow structures.
Very good. Hollow viscera. So colics typically arise in hollow viscera. Like bowel, can you tell me another hollow viscera in the body which patients come to the casualty wards with pain?
Urinary tract.
Very good. Ureteric colic. Okay. So colics typically arise in hollow viscera. Okay. By nature, this colicky abdominal pain that somebody has in intestinal obstruction is waxing and waning. So there are peaks and troughs. It's poorly localized. Why? This is visceral pain. So I would like you all to actually, one of the things I would like you to go back and read in your basic sciences is the difference in character between somatic pain and visceral pain. Visceral pain is pain that arises in the viscera, in the hollow viscera, like the bowel, like the ureter. The pain pathway fibers go through the autonomic nerves into the spinal cord and to the higher centers, in contrast to somatic pain, which passes through the spinal nerve roots, through the somatic nerves. So colics that arise from hollow viscera are the type of pain that you have when you have a visceral pathology, like in intestinal obstruction. And if you have a pathology, let's say you burn your hand or you get stabbed in your abdominal wall, the kind of pain that you have is different, though the site might be adjacent to each other. So physiologically find out what is the difference in character between visceral pain and somatic pain and why. What is the physiological basis for this difference? So the pain that is felt in intestinal obstruction is typically a colic. The reason for the colic is, as you see, there's a hollow viscera, there is some obstruction, so the bowel proximal to the obstruction starts getting distended. And when there is distension, the natural reaction of the bowel is to go into spasm and try to push the contents beyond the obstruction. And when that happens, it generates a colic when the bowel goes into spasm. Now, this colic, the region in the abdomen this colic can be felt is variable. Sometimes the colic is like a diffuse central abdominal pain. It's felt periumbilically or in the circumumbilical region. Sometimes this pain is infraumbilical or lower abdominal in the pelvic region. Can somebody tell me the reason why you might have the differences in such pain? The ones that you feel low down in the lower abdominal region versus those you feel diffusely central abdomen. 1209. Mohan or Mohan. Yeah, it's 1209. Are you there? 1209, I can see you there, but I don't see any reaction. Who is Mohan or Mohan S?
Sir, excuse me.
Yes, go on.
Sir, sorry, I heard my name, but I couldn't hear the question properly. Can you please?
You heard your name, but you couldn't hear the question. That's interesting. So you've not been following what's going on, is it?
No, sir, it's like cutting.
Okay. So I said colics can be felt in different regions of the abdomen, either diffuse central abdominal pain or low abdominal pain in cases of intestinal obstruction. My question is, why would you have different regions of pain like this? Different
It depends on the
areas of visceral. Yes, go on. Yeah.
Yeah, it depends on the place, like the organ, that's large intestines or the small intestines.
So, where would you feel pain of? Can you give me an example? Why do you feel pain of small intestine in a place and large intestine? Is it just by the fact that it is large and small, or is there some other basis for this? Okay, I'll give you a clue, and the clue is it's related to the embryological development of the bowel.
It's about the origin, sir.
So
like
what about
midgut?
Yes, you're right. So that's the reason. So bowel that originates from the midgut, if there's a pathology or spasm of bowel that originates from the midgut, it's generally felt diffusely and central abdominal. Whereas pain that originates from what's the other gut we're talking about here?
Hindgut.
Hindgut is felt in the pelvis or lower abdomen. Now, can you tell me what the demarcation between what area of the intestine is encompassed in the midgut and what area is encompassed in the hindgut? This is from your anatomy days.
So the midgut will be the proximal 2/3 of the transverse colon, and after that is the hindgut.
Yes, so the hindgut begins from the distal third of the transverse colon right down to the dentate line. Yes, and so the midgut is
From the distal, from the duodenum, second part of the duodenum to the.
Yes. So basically, all the small bowel from the second part of the duodenum or duodenogenital flexure, right up to the mid or distal transverse colon is midgut. So this pain, this is basically the principle is what you would have studied or learned in physiology. This is visceral pain referred to the corresponding somatic segments. And that is why you feel pain from this that originates in the small bowel or proximal large bowel in the central abdomen, and you feel pain that originates further distally in the distal large bowel in the lower abdomen. Okay, so in intestinal bowel that is distended due to a lesion even in the large bowel, even the small bowel can be distended. So you can have a combination of both. Now this pain, this colicky pain that we talk about also causes certain other symptoms. Just the pain itself. Can somebody say what are the symptoms it causes? Who would like to answer? 1244. Rodrigo WDMS.
Yes, sir.
Yes. So we are talking about pain in intestinal obstruction, and when somebody has colicky pain, what are the other associated symptoms that come up with a colic? You would have seen patients who came with intestinal colics in your casualty ward, patients who had ureteric colics. What were the other symptoms they had that were associated when they had this intense pain?
Nausea.
Good.
Yeah,
Nausea, vomiting, yes.
Cramping, like.
Yeah, so the cramps are the colics, but yes, nausea, vomiting, anything else that's very common in these patients? When you look at them, they look very ill and they are, what else? Sweating, isn't it? You find that they are sweating, they have nausea, vomiting. Now, why do you think they get these symptoms? This nausea, vomiting, sweating. What's the reason?
Because of sympathetic activation.
Yes, it's actually an autonomic reflex. Okay. The reason for this is because the pain fibers from hollow viscera, as we described earlier, that the pain fibers that pass from the gut, taking the pain, pass through autonomic nerves, the sympathetic and parasympathetic nerves. And as a result of that, it triggers the autonomic nerve system and it causes the symptoms you described. Nausea, vomiting, sweating, and so on. Okay. So it's important to understand the nature of pain that one has in intestinal obstruction, and that's primarily because the gut is distended. Because there is obstruction distally, proximally there is distension, goes into spasm, and all the things that we described occur. Okay. Right, let's look at another symptom. Abdominal distension, another cardinal feature of intestinal obstruction. Why is this there? Because the gut fills with either gas or flatus, if we may call it, fluid. A lot of this fluid, where we will ask somebody, what is this fluid that the gut fills up with? Who would like to answer? 1274, Thatsarani WB. What is this fluid we are talking about? How does fluid collect in the gut? One, 2, 7, 4, Thatsarani. Yes, Tatsaran, we are waiting. You'll have to unmute your mic, Tatsaran. Okay. What is the reason? Where does the fluid in the gut come from? Yes? Can you hear us, Tatsaran? We are waiting. Can you hear us?
From intestinal secretions.
Ah, there you are. What happened? Were you also unable to?
Sir,
Okay,
my
go on.
connection is not good because of
okay.
the bad weather.
Right. Okay. Don't get electrocuted. Yes. Yes. Intestinal secretions. Good. What else? So this is from the gut. What else? Okay. Somebody else help her. I think she's having connection problems. Who is SA Sekanayaka, 1144.
The secretions from the gut.
Okay. Okay, so small bowel secretions, isn't it? You can have a lot of secretions, especially when there is distension and spasm. Intestinal secretions increase. But what else joins this? If you remember your gastrointestinal physiology, what are the other substances that put secretions into the intestine? Or what other organs?
Biliary secretions and
Yes, bile
pancreatic
and
secretions.
pancreatic juice. Yes. So all these, a lot of secretions start getting into. So when there is intestinal obstruction, you have all this collecting, and because the gut is in spasm, reabsorption into the gut is less and secretion is increased. So a lot of fluid collects inside the intestine. And in addition, of course, there can be fecal matter, which is partly digested food and discriminated epithelium. So all these collect within the intestine and lead to distension. The other symptom we talk about frequently is vomiting, right? And we saw a little earlier that one of the first, when somebody has intestinal obstruction and they have pain and they got a colic, vomiting occurs as a response or an autonomic response to the colic. We saw that the pain fibers go through those same nerves. Now, when you have a patient with intestinal obstruction, if they are vomiting, it is important to find out what the type of vomiting is. We will see further why this is important. Sometimes the vomiting can be bilious, that is, it's bile stained. Sometimes it's non-bilious, and sometimes it can be feculent, that is, it can look like fecal matter or watery fecal matter, feculent. So you have the different types of vomiting that can occur due to obstruction. I just want to ask somebody, let's see, Kirtana V. Kirtana, can you tell us if you had somebody who had bilious vomiting, that is vomiters with bile, and somebody without bile, what does that tell you? What's the difference between bilious and non-bilious vomiting? If it is due to obstruction.
Bilious vomitus, maybe due to gastric outlet obstruction.
Is it bilious or non-bilious due to gastric outlet obstruction?
Non-bilious. Bilious one is
Non-bilious.
small bowel obstructions with when the bile
Yes.
enters.
Yes. So it basically, if you have non-bilious vomiting, as you rightly said, it generally indicates that this is gastric contents, right? So it may be gastric outlet obstruction. Sometimes it's just a gastroenteritis. You may have some other reason why, whatever the reason is, you vomit, or as a result of a autonomic response to a colic, if the stomach empties, you will have non-bilious vomiting. But bilious vomiting basically tells you whatever the pathology, if it's obstruction, is usually distal, or it's distal to the opening of the ampulla or the ampulla of Vater. So it is usually small or proximal or distal small bowel obstruction. When talking to patients, it's important to also find out, when you take a history, if they say they're vomiting, not only to find out what the nature of the vomitus is, how the volume of the vomitus is, but also to find out when they started vomiting in relation to their illness. Whether the vomiting was started very early on in the illness, or did it come on late? Because that will help us try to determine the site of obstruction. Okay, so we'll look at that as we go along. Then we have the other symptom, constipation. Again, we need to find out, has this constipation been something that has been there for a prolonged period of time? Is it something that came on very rapidly, suddenly? Generally, when you have acute constipation, it tends to indicate there is large bowel obstruction, usually left colon or distal large bowel obstruction. Again, the timing is important. So if you have constipation developing late in the onset of disease, it generally says that the obstruction is proximal in the small bowel rather than large bowel. There's another term you might have heard called absolute constipation. During your clinical appointments, you would have heard, or your consultant or in your ward, people would have talked about this thing called absolute constipation. Can somebody tell me what you understand by this? Absolute constipation? What do you mean by absolute constipation? (1198) Liana Patiran. You all want me to call your names out, I think. Yes.
Yes, sir. So, no stools at all.
Yeah. Okay, no stools at all. It's a little more than that. When you talk about absolute constipation, it is the absence of the passage of feces and
Flatus.
yes, there are only two things that we pass that way, no? Yes. So when you talk about absolute constipation, it's not just the absence of passage of feces, it's also the absence of passage of flatus. Very basically, nothing is going out downstream. And that is usually, clinically, it's a manifestation of distal large bowel obstruction. Okay, if somebody comes and tells you they're not passing any flatus, they're not passing any feces, and it has come on there early, fairly rapidly, then that's usually acute large bowel obstruction. Of course, absolute constipation can occur in other conditions as well. We'll see as we go along, but this is one of the important things to ask patients when they have constipation. Okay, right. So let's see. So we've looked at some of the key clinical features of intestinal obstruction. And remember, not everyone will have all those clinical features. Some will have some, others will have others. Some may occur early, some may occur late, and these give us a clue as to the likely site of obstruction and cause. So intestinal obstruction, generally we broadly divide it into two in terms of etiology. The cause of obstruction can be either mechanical, which means there's something actually blocking. And mechanical obstruction may be within the lumen of the bowel, intramural, like there can be a bezoar, sometimes there's rarely something called gallstone ileus. It can be in the wall, like a malignant growth that's arising from the wall, which is actually partly mural and intramural, thickening, strictures. And it can be something outside the wall, extramural, which means there may be a band or a adhesion or some other thing that is compressing, or another adjacent organ that is compressing the bowel and preventing passage of intestinal content. So mechanical intestinal obstruction can be in any one of these components of the bowel, within the bowel, in the wall, or outside. Now, there's another type of intestinal obstruction which is called functional. In that, there is no obstruction as such. The bowel is nice and patent, but there is a problem with normal peristalsis. So this is a time again for you to go back and look at your gastrointestinal physiology and understand that for there to be passage of intestinal contents from the mouth or food from the mouth right down to the anus, you have to have effective peristalsis. And that is a very complex procedure. And if there are things that go wrong in the neurohormonal regulation of this effective peristalsis, you can have functional obstruction. We'll look at some of the causes of functional obstruction as we go along. You can also classify intestinal obstruction as to whether it is complete or partial. So if the bowel is completely obstructed, as the term indicates, nothing goes beyond, then obviously the manifestation of symptoms are more rapid and more severe. Whereas when it's partial, especially in the early stages, it may be difficult to really diagnose or detect that this person has intestinal obstruction because there is a little passage of stools, there isn't complete obstruction. They may have a little nausea, fullness, vomiting, but not as severe as when it is complete. So it can be partial obstruction. The obstruction can, as I mentioned earlier, come on very suddenly, or it can come on at a matter over a period of a few weeks or so. Subacute. So acute means it comes on within hours or a day or so, whereas subacute can take maybe a week or more. And the site of obstruction, commonly it's either in the large bowel. In the large bowel also you can say distal large bowel, proximal large bowel, and the small bowel can be proximal or mid or distal small bowel, jejunal or ileal. So based on various factors, you can have different types of obstruction. You can be classified in various ways. So just let's have a little look at what this functional obstruction is. And one of the commonest causes of functional obstruction, and this is something you may have seen in your wards, is patients after abdominal surgery, after a laparotomy. They can have post-operative what is called ileus. You must have heard this term, paralytic ileus. Basically, the bowel goes on strike. The intestines, just because of the handling of the bowel, sometimes it's desiccation, and various other reasons, the bowel does not function properly. And these patients take a long time sometimes to pass flatus and open bowels after surgery. And so if you start feeding them too early after abdominal surgery, when they have paralytic, or if they have paralytic ileus, these patients develop distention and vomiting. It's a very common cause of functional obstruction after abdominal surgery. Then the other things that you see here, peritonitis, either chemical or bacterial peritonitis, if there is blood inside the peritoneal cavity, if there are inflammatory processes going on in the abdomen, like for instance, acute pancreatitis, all these are like insults. The bowel doesn't like all this. It doesn't like foreign substances. It doesn't like inflammation taking place there, and it goes again on strike and it doesn't function. So they all cause functional obstruction. Metabolic cases, especially hypokalemia, can also cause functional obstruction. And there are certain other neurohormonal conditions. You can go and read something about intestinal pseudo-obstruction. Yeah, you can have obstruction in the absence of any mechanical blockage of the bowel. So these are, go and read something about the functional causes of intestinal obstruction. Read about paralytic ileus. Okay, so that you know what's going on. Now, how do you generally, how can you differentiate somebody who has got mechanical intestinal obstruction from somebody who has got functional intestinal obstruction? It's not always easy or clear cut, but in general, in both of them, though you have distension, abdominal distension can be more prominent in functional obstruction. So there is gaseous distension, but what they don't have for that amount of distension is pain. So if somebody has got paralytic ileus or functional obstruction, they do have minimal pain or no pain. Okay, so that's a very important, one of the important ways in which we help to differentiate it. And as I told you, they can have vomiting, poor tolerance of oral intake, and usually there is a preceding or an antecedent cause. So you will find that this patient has had surgery, or they've had a septic focus in the abdomen, peritonitis, pancreatitis, some sort of cause is present in the history or the past of this patient, which may tell you this is possibly or likely to be paralytic ileus. So there's an antecedent cause. And when you listen to you put your stet on the abdomen and you listen, they generally have their bowel sounds are sluggish. Why? Because these intestines have gone to sleep. Unlike in mechanical obstruction where they are going into spasm and trying to push things across, in paralytic ileus, the bowel sounds are absent. You can't hear anything. It's a silent abdomen because of very, very minimal bowel sounds, because the intestines are atonic. They are not, there is no peristalsis. Okay, so these are some of the clinical features by which you can differentiate functional from mechanical obstruction. Okay, so let's move on. So when we get a patient, let's say you're the doctor in the casualty surgical ward and your surgeon comes for a ward round and you have a patient with suspected intestinal obstruction, these are the important questions we really want to answer. A, is this mechanical or functional obstruction? If it is mechanical obstruction, it's very simple. We want to know where is the obstruction. Proximal small bowel, mid small bowel, distal small bowel, large intestine, where? Where is the obstruction? What is causing the obstruction? And are there any complications of this intestinal obstruction? So these are the questions we really want to answer. Where is the obstruction? What is causing the obstruction? Are there any complications of this obstruction? And all our history, our examination, our investigations, imaging are geared to answering these questions. Okay. And how do you diagnose these? Remember, even in this day of technological advance, intestinal obstruction, the diagnosis of the site, the cause, as I told you, is still primarily a clinical diagnosis. That is, we need to talk to the patient, we need to examine the patient, and radiology functions as what we call an adjunct. It assists us to make this diagnosis of intestinal obstruction. Okay, So still, that is why it's extremely important to listen carefully, to question the patient carefully, examine the patient carefully, and come to a diagnosis. So remember, the diagnosis of intestinal obstruction is clinical, and radiology helps the clinical diagnosis. Obviously, I'm not going into all the details, but some of the key important things that you need to know. Obviously, the age of the patient, because causes of obstruction in young patients are not exactly the causes of obstruction in older patients. So infants can come with different causes of intestinal obstruction. Teenagers or young patients might have different causes. Elderly patients can have different. So the age itself can give you a clue as to what the cause of intestinal obstruction is. Like I told you, the sequence and predominance of those key symptoms, the distension, the vomiting, the colicky pain, and the constipation. Which of these symptoms came first? Which of these symptoms predominates? These give you an idea as to whether this is proximal bowel or distal bowel. So the history is very important. The distribution of pain, previous history. Has this patient had surgery before, for instance? Is there any history of altered bowel habits like altered or constipation, rectal bleeding, and so on? Okay, so the previous history might give you a clue. When you examine these patients, it's very important in your general examination to look at the hydration. We will be looking at hydration again later and their hemodynamic status. Obviously, your abdominal examination is key. I've told you the key things that you need to see. And you need to do a digital rectal examination because that gives you a clue also about where this obstruction could be. Now, when you did your appointment, sometimes you might have seen your registrar or whoever do a rectal examination and say the rectum is empty. What is the significance of an empty rectum? Anyone can tell me, work out? Let's say you normally when you do a rectal examination, you will have a little bit of stools or something. If you have a patient who comes with features of intestinal obstruction and you put your finger in and you find there's nothing. It's like you're in space. What do you think that would be? 1270, Subodhini. What do you think, Subodhini? Let's say you were given that you were the house officer, you did your rectal examination and you found the rectum was empty. You take your glove finger out and it looks like a brand new glove. Nothing there.
Due to obstruction in the colon.
I think the obstruction is more proximal or more distal?
Distal.
I'm asking you distal. So when you say distal, where distal? How distal do you think? Usually. You're right. What you said is right. Now, yes, somewhere. So you're looking at obstructions probably in the sigmoid, yes, descending sigmoid and rectum in that region, your left colon generally. Do you know why that is so? Why is it that in proximal, now let's say if there is an obstruction in the jejunum, proximal small bowel, why is it that the rectum will not be empty? Whereas if there is an obstruction in the rectosigmoid region, you know, like you said, the distal small bowel, the rectum is likely to be empty. Can you say why?
If the obstruction is in jejunum, the secretions distal to the obstruction can be in the rectum.
Absolutely. Perfect. So if you have obstruction proximally, like we said, all the intestinal contents that are secreted, and if you remember your physiology again, a large part of the feces that we pass is not what we eat really. What do you think makes a large part of our feces, Subodhin? In addition to the food we take, what is a large part of the content of feces?
Uh, mucus and secretions.
Okay, the secretions and a
Bone.
solid, sorry? There is a very high turnover of intestinal epithelium. So all those desquamated intestinal epithelial cells and microbial flora all contribute to the feces, the bulk of the feces. So if you have a proximal bowel obstruction, all that will still come downstream and the person will be still passing or may have feces in the rectum. Whereas if it is in the rectum or the rectosigmoid or a distal sort of colon, there is hardly anything to pass. Is that clear to you? The significance of an empty rectum generally means that the obstruction is distal. And we are talking about left colon rectosigmoid region. Okay, and that's the basis for it. That is why you have that. So this is just an example, right? So in general, if somebody has proximal small bowel, or if we say proximal jejunal obstruction, the most important symptom will be bilious vomiting. Most of the time, these patients will tell you that they get this vomiting about half an hour to 1 hour Okay, guys, I'm sorry I lost you all. I think there was a small power issue. Let me get. You all see the screen now?
Yes, we can see.
Okay, I think this is where I got knocked out. Okay, so like I was saying, if you have proximal small bowel obstruction or jejunal obstruction, the predominant symptom, early symptom is bilious vomiting, and it's usually seen about half to 1 hour after the meal. There is hardly any abdominal distension, there is hardly any pain, and the patient will be still passing stools. And for this reason, proximal small bowel obstruction is sometimes missed because it's not, other than for the vomiting, you don't see the other cardinal features of intestinal obstruction. And quite often these patients are just treated with antiemetics, or they are treated for peptic ulcer disease with proton pump inhibitors and so on and so forth. So it's sometimes missed. The other thing on the other extreme is distal large bowel obstruction. And in distal large bowel obstruction, what you usually see is the opposite of this. Constipation, or what we call absolute constipation, is the predominant symptom. These patients have gross abdomen. The abdomen is grossly distended. Why? The large bowel is a large capacitance hollow viscera, so a lot of gas and a lot of feces can collect, and it causes huge amount of abdominal distension. Vomiting is not a predominant feature, and it can occur later in the course of the illness. So basically, looking at the sequence and the predominant symptoms that are present, we can somewhat localize where the intestinal obstruction is taking place. Now, I told you intestinal obstruction is primarily a clinical diagnosis. Having said that, we use imaging to help us with this clinical diagnosis. And if you're asked, then what is the most important image? And this can be, it's a simple investigation that can be done in any hospital in this country. That is a supine abdominal X-ray. Not an erect chest X-ray, not an erect abdominal X-ray, but a supine abdominal X-ray. Because a supine abdominal X-ray will show you the distribution of gas shadows. It will show you the diameter of the bowel tubes. And it can also show you if there is bowel edema. And there are certain characteristic appearances in certain conditions. We will see one or two later. When there is uncertainty, sometimes we also use a CT abdomen with oral or rectal contrast to figure out where the obstruction is. Now you have some homework to do, and you have some time to go and read and have a look at a few images. And that is, you need to be able to see, if you look at an X-ray, how would you be able to differentiate between dilated small and large bowel loops if you see a supine abdominal X-ray? So next time you're in a ward and you have a patient with intestinal obstruction and they do a supine abdominal X-ray, look at it and try to figure out, is this large bowel or is this small bowel that is distended? You can also look online. There are several images of this, and learn how you can differentiate the two based on where it is, based on the lines that you see. Okay, find out how you differentiate these two. There's another kind of intestinal obstruction that you may have heard about and people will talk about, and that is called closed loop obstruction. Right? Closed loop obstruction. Now, what is closed loop obstruction? Now, if you take a hollow viscera like that intestine, right? Let's say it's like that. If you have obstruction at 2 points, so if the loop is closed, so let's say this is a loop of intestine, right? Usually you have obstruction here in one area, the proximal small bowel dilates or large bowel dilates like that. If there is some constriction at 2 ends for any reason like that, that is called closed loop intestinal obstruction. I've given you some examples. Now, if you see this is the sigmoid colon, the descending colon, the transverse ascending colon, and the cecum. Now, let's say we have a tumor here, a rectosigmoid tumor. The small intestine opens into the cecum. The terminal ileum opens into the cecum through what is called the ileocecal junction. At the ileocecal junction, there is a valve. Now, if the ileocecal junction or the valve in the ileocecal junction is competent, it works, it will not allow anything from the large bowel to reflux back into the small bowel. So what happens? Everything starts coming bit by bit into this. This starts getting bigger, 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 and dilating. And you have an obstruction here, a physiological obstruction because of the competent ileocecal valve, and a pathological obstruction there because of a tumor. And this then becomes an example of closed loop obstruction. Okay? Closed loop obstruction. Another example I have put is here. Let's say you have somebody has a hernia and this is a defect, the neck of the hernia. A loop of small bowel comes out through this hernia like that. Now the ring, this tight ring, the neck of the hernia, then constricts the bowel in 2 places. Okay, the afferent loop and the efferent loop. This then becomes a closed loop. Why? It's closed at both ends. These are examples of what we call closed loop intestinal obstruction. Now you might wonder what's so special about this. Closed loop intestinal obstruction has a higher complication rate compared to non-closed or conventional intestinal obstruction. That is because this closed loop obstruction, if you see, has a small loop which dilates much more than non-closed loop, and it also has an element of what we call vascular compromise because the blood vessels here to this entire loop can be compromised. So complications like bowel ischemia and perforation, complications of intestinal obstruction like bowel ischemia, strangulation, and perforation are higher in closed loop intestinal obstruction. Now I'm going to ask you a question about this. Now we said that this, let's say there is a rectosigmoid junction cancer. There is a competent ileocecal valve, so everything that collects in here cannot go back, and this colon starts getting more and more distended. Now when the colon gets beyond a certain diameter, there is a risk of perforation. Can somebody tell me where this colon is most likely to perforate? If there is a rectosigmoid tumor here, is it the descending sigmoid colon, descending colon, transverse colon, ascending colon, or the cecum? Where is perforation most likely to occur? if there is complete obstruction at the rectosigmoid. Who's going to tell? Anyone? One 1158 GAHG Gunasinghe. What do you think, Gunasinghe?
Figure.
Yes, you're right. My answer absolutely correct. It's a cecum that is most likely to perforate. My next question to you is why?
The wall of cecum is thin.
Actually, the wall of the cecum is not thinner than the rest of the large bowel. It's something to do with the cecum, and there is a principle in physiology which you would have learned when you did your physiology. If you put those together, you will get the answer. So you're right, it's a cecum, but why? Anyone wants to help him? Any ideas?
Law of Laplace.
Who is that? Gunasekara. Yes, excellent. The answer is absolutely that. It is the law of Laplace, right? So, can you just tell your colleagues what this law of Laplace is and how it applies to the cecum? Very good, excellent.
When the radius of a hollow viscous increases, the wall tension will also increase.
Okay, so
Therefore, when the feces is collected and it swells, there is a risk of rupture.
yeah, very good. So inside this hollow viscera, this entire colon, when there is an obstruction here, the pressure, the intraluminal pressure is the same. The pressure here, the pressure here, the pressure here, the pressure right along this is the same. But the diameters are different. So the cecum is the part of the large bowel with the largest diameter. Okay. So the tension in the law, if you take the law of Laplace, so if the diameter increases, then the pressure is the pressure here is the constant. For every small increase in the diameter, the tension developed in the wall is much greater. Okay, so when the tension is greater, the perforation occurs here. So this is a good example of physiological principles coming into play. So go and read about the law of Laplace and think about this principle. Okay, so the cecum is the place that perforates if you have a distal rectosigmoid tumor. The pressure is a constant, the diameter is a variable here, and therefore the tension developed in the wall is a function of the diameter of the hollow viscera. Okay, and therefore it perforates. Okay, so a quick look at some of the complications of intestinal obstruction. The complications can occur in the bowel. One of the important complications we are concerned about is ischemia and gangrene. And I told you in closed loop intestinal obstruction, we are very concerned about this. We have to be very vigilant and pick it up early. Like we saw, if there is perforation, then there can be peritonitis. The other important thing you need to be concerned about is if you have gross abdominal distension due to large bowel obstruction, for instance, that pressure in the abdominal cavity, the intra-abdominal pressure can rise and keep the diaphragm splintered. It can prevent the diaphragm from contracting and moving down, and it can cause significant respiratory compromise in patients, especially in patients who are elderly, in patients who have previous respiratory problems. So if somebody is a smoker, has got chronic pulmonary disease, obstructive pulmonary disease, if they have further compromise of their respiratory, because they've got a very small reserve, then it can cause significant problems. And the other huge problem that patients with intestinal obstruction have is due to fluid and electrolyte depletion. They can go into shock, they can go into acute kidney injury, and they can have various acid-base imbalances. So these are some of the complications of intestinal obstruction. Okay, they can be related to the bowel itself, they can be related to raised intra-abdominal pressure, and a large amount of them are due to fluid and electrolytes. So basically loss of sodium, potassium, and in some instances hydrogen ion that causes these problems. There is especially prolonged vomiting. This is the complication that we would like to identify early, especially so. And that is called strangulation or bowel ischemia. So you would have heard this again in your surgical casualty wards in the discussions. When patients come with intestinal obstruction, we don't take them immediately and operate them. We keep them, we observe them, we do various resuscitative measures. But things become urgent if we suspect that there is ischemia or impending ischemia or bowel gangrene. Because if you allow bowel to become ischemic, gangrenous, and perforation occurs, that causes significant morbidity and mortality in patients. So we should be able to clinically and biochemically be able to pick up those patients with intestinal obstruction who may have early evidence of bowel ischemia. And there are various ways. Clinically, you will find that the patient's pain, the character of pain, what was we described initially, colicky pain, up and down, that colicky pain becomes a constant, very severe pain. Okay, so there may be a change in the character of pain. The patient becomes more tachycardic, more breathless, tachypneic, despite adequate fluid resuscitation. Their urine output starts dropping. They start getting a bit of low grade, the fever, temperature starts going up. And if you do their white cell counts, it might start rising, the C-reactive protein may rise. And a very important indicator of bowel ischemia is this thing called lactic acid. And in our setup, we usually look at lactic acid, or the way to assess lactic acid is in an arterial blood gas analysis. An arterial blood gas analysis will tell us what the serum lactate is, because if there is bowel ischemia, the lactic acids start going up. But remember, you can have significant bowel ischemia in certain conditions even without the rise of lactic acid in the blood. So that also you need to know. Okay. So again, if you suspect that there is bowel ischemia, you need to go and operate on these patients because otherwise you might lose them. Okay, and these are some of the ways in which we identify that the patient might have strangulation or bowel ischemia. I would like you to go and read a little about lactic acid metabolism. What are or where is lactic acid formed, under what conditions is lactic acid formed, what happens to it once it comes into the circulation, how is it metabolized in the liver. This is a good time to go and revise that. There is a certain cycle that is involved in the liver. Anybody can tell me what cycle is involved in lactate metabolism in the liver? When somebody has lactate comes through the portal vein into the liver, what happens to it? There is lactic acidosis. Let's see. 1264, Serena.
Core cycle.
Very good. Excellent. So lactate is channeled into the Cori cycle, and then it finally enters the pathway of glucose metabolism. Okay, so this is a good chance for you to go and actually revise what happens when there is lactic acidosis. Okay, so we've looked at bowel ischemia. Now, this is another important thing that you must appreciate, and that is dehydration or fluid depletion is an important problem in intestinal obstruction. Several reasons for it. One is when they have intestinal obstruction and they're vomiting, they don't take in fluid. There's poor intake. Number two, there is vomiting. Number three, they can be hyperventilating. There is what we call the insensible loss. The thing that we don't see, okay, the hidden loss in intestinal obstruction is this sequestration of fluid in the gut. I told you when there is intestinal obstruction, the gut goes into spasm. It tries to bypass the obstruction. There is increased metabolism in the gut. And as a result of that, a large amount of secretions enter the gut. And reabsorb what normally when these secretions pass through the bowel, they get reabsorbed in both the small intestine and large intestine. This reabsorptive capacity is also impaired. As a result of that, a lot of fluid actually collects in the gut. Liters and liters of fluid can be collected in the gut. And when we do our fluid balance charts, we miss this because you're not seeing it. And we underestimate very often the fluid losses in a patient with intestinal obstruction. So it is very important to remember this aspect of fluid loss in intestinal obstruction and adequately hydrate these patients. And this also tells you the importance of maintaining an accurate fluid balance chart in patients with intestinal obstruction, because otherwise these patients will become dehydrated, they will lose fluid, and before you know it, they'll be in acute kidney injury and other organ dysfunction. It's a very, very problematic thing that we see in intestinal obstruction. So be very, very aware of dehydration and its causes. You need to calculate, all these can be calculated, the vomiting, the insensible loss, urine output, and so on. This you will not calculate, so therefore you need to give your fluids beyond what you think is the normal losses, because they are fluids sequestered in the gut. These are the common biochemical investigations. So we would always do a creatinine. It gives us a baseline renal function and also indirectly tells us what the fluid status is like. Obviously, you would do the sodium and the serum electrolytes, because with vomiting and with sequestration of fluid in the gut, they will lose a lot of sodium and potassium. And the arterial blood gas analysis helps us, as I told you, it will help us with acid-base imbalance. So if somebody has prolonged vomiting, they may have a metabolic alkalosis. If they've been dehydrated for a long period and they are volume depleted, they may have metabolic acidosis with a high serum lactate level. All those can be detected using the arterial blood gas analysis. So these are, apart from this, obviously you would do your baseline full blood counts, your C-reactive proteins, chemical investigations that you need to do. What are the principles of management of patients with intestinal obstruction? You would have seen all of them have a or most of them will have a nasogastric tube and drainage. Can somebody tell me why we put a nasogastric tube? What is the purpose? Why do we have a nasogastric tube for patients with intestinal obstruction? Anyone? 1261, LAP Silva. Good evening, LAP Silva, 1261. Unless you.
Yes, sir.
There you are. Yes.
Uh,
So why have you seen patients who have obstruction with a nasogastric tube when you were doing your appointment? No. So all your patients in the surgical ward were there were no sick patients during your surgical appointment. Nobody had intestinal obstruction. Never mind. That's okay if you haven't seen. If a person has intestine, one of the important things we do is we put a nasogastric tube. Do you know why? Why do you think? The nasogastric tube is in the stomach. What do you think the stomach? Yes, go on. Yes.
it can remove fluid and gas.
Okay, so when there is intestinal obstruction, let's say there is ileal or small bowel obstruction, there is collection of all this in the gut. So what happens when the fluid starts collecting? It comes back, and where does it then starting to collect? In the stomach. And then when it collects and the stomach is distended, and when there is reverse peristalsis, what do these patients have?
They can acid reflux and aspiration.
Yeah, so they vomit. Vomiting is one of the cardinal features. So, like you said, we put the nasogastric tube to decompress the stomach. Otherwise, it's patient will be vomiting and retching, and it's not a pleasant thing. And like you said, there's a danger of aspiration, especially in older patients. All those contents can go into the lung. So the nasogastric tube's function is to decompress. So it decompresses the stomach. So air, fluid, everything that refluxes back then comes out through the nasogastric tube. By decompressing the stomach and the intestines, you see when the intestines are grossly distended, I told you it goes into spasm like this, right? But after a while, they get tired and they become atonic and they lose their tone and they become like paralytic ileum. So one way to get the bowels to function again is to reduce the distension and tension on the bowel. So when you decompress the gut, you're actually helping the bowel to recover. So nasogastric tube drainage is important. One is it tells us, or it helps to decompress all this and prevent vomiting, aspiration, and so on. The other is we have some idea of the sequestered fluid in the gut, because what comes out through the nasogastric tube, we can calculate and say this is also lost and keep that as additional replacement fluid. So the nasogastric tube serves a very important purpose. Obviously, we have to give fluids, electrolytes. Patients have colics, so you would give them opioids like morphine for pain relief. As I told you, very important to put a catheter in these patients and maintain a fluid balance chart and monitor vital parameters, look for complications like bowel ischemia. And once we've resuscitated these patients, if they don't resolve, then we go for definitive care, which is usually surgery. Sometimes there are certain endoscopic procedures you can do, but most of the time it is surgery if the intestinal obstruction doesn't settle. But before that, you need to resuscitate these patients, keep them, especially important that we correct their fluid deficit, electrolyte deficit, and correct any acid-base imbalance they have. Having done all that, you can take them for surgery if the intestinal obstruction doesn't settle. Right. Now I'm going to just touch on a few examples of types of intestinal obstruction that you may have come across or you will come across when you're doing your appointments, and you may have heard these terms. One is this thing called a volvulus. Okay, so you may have come across patients with what is called a sigmoid volvulus. So a volvulus, as you can see, if you look at this image, is where there is a twist, a loop of bowel twists upon itself. Now, for that to occur, there are certain characteristics. Twists cannot occur in bowel that is fixed. For instance, you cannot have a volvulus of the descending colon or ascending colon. Why? Because they are retroperitoneal, fixed structures, they cannot rotate. So for a volvulus to occur, there are certain characteristics that need to be satisfied. One is the chance of a volvulus occurs if there is mobile bowel, so bowel that is on a mesentery, right? Small bowel, transverse colon, sigmoid colon, things like that. Those are the ones that can rotate. The chance of rotation is higher if the base of the volvulus, if you look at, when I say base, this part, is narrow. So the narrower the base, the broader and the longer the mesentery, the greater the chance it can rotate or twist. And the two organs that mostly meet this kind of criteria are the sigmoid colon, you can see here, and the small bowel. You know, the small bowel is, if you think of the small bowel, it's on a very narrow pedicle. I have got several feet of small bowel on that narrow root of mesentery, with the small bowel mesentery like a fan. If you think about it, it's opened out like a fan. So it can actually twist. Similarly, if you think of the sigmoid colon, you can have a very long redundant sigmoid colon with a very small narrow base, and it can easily twist upon itself. And when that occurs, you have what is called a sigmoid volvulus or a small bowel volvulus. In the sigmoid colon, when you have this very characteristic appearance. This image that you see here is a very characteristic appearance of a sigmoid volvulus. Who would like to tell me what this characteristic appearance is? What does it look like? Kularatna DMB 1188. Yes, Kularatna. You see this appearance here? This is a sigmoid volvulus appearance. Do you know what this characteristic appearance is described as? If you see this X-ray, you know it's a sigmoid volvulus. You see this kind of thing like that, and yes, Kularatna. Yeah. Any idea? Any thoughts? Anyone else? Yeah, go on, Kularatna. You're starting to say something. Go on. Hemasinger, 1164.
So is it the coffee bean sign?
Excellent. Yes, it is. So, if you look at this, if you haven't seen a coffee bean, then maybe this will tell you what a coffee bean looks like. So all of you can go and have a look at a coffee bean if you haven't. This is the coffee bean with that central groove, typical appearance of a sign. It typically is described as a coffee bean sign or coffee bean appearance. Okay, this is a loop that is twisted upon itself. Closely dilated sigmoid colon with this groove, which is actually where the mesentery is, where it is twisted. Okay, so this is what you see in a sigmoid volvulus. Let's look at some other examples. This is another one that you might come across, especially anybody knows in where when you work in a particular place, you might come across this more commonly, intersusception. So intersusception basically means you see this is a loop of bowel, this is another loop of bowel. There is telescoping of the afferent or the proximity to this light. And when it does that, it causes obstruction. This is a real life picture. You can see this loop of bowel has gone into this. And when you pull it out, you can see that that's a constriction. And there is something called a lead point. There is usually some sort of thickening. It may be lymphoid hyperplasia or a small tumor or a polyp that the bowel thinks is part of the content of the intestine. And so it actually, during the peristalsis, it gets dragged like this into the distal bowel. Okay, and it results in this thing called an intersusception. A very common site is in the ileocecal. So the ileum intersuscepts itself through the ileocecal junction into the cecum. In whom is this seen commonly? Anybody? Intersusception? You all can go and read more about it, but anyone knows who it's seen? Gayashan, TLC Gayashan, 1152.
Yes, sir. In
So
children.
Gayashan, do you know in which? Very good, in infants, isn't it? Ileocecal intersusception in a so when you're doing pediatrics or pediatric surgery or pediatrics, you might come across infants with intersusception. It's quite common in them. Can occur in adults as well, but it's more common in the pediatric. This is the other common cause of intestinal obstruction you will see in your surgical wards. That is an obstructed inguinal, femoral, or sometimes paraumbilical. It could be any hernia for that matter, but it is generally a hernia which has got a narrow neck. And this is, I told you, an example of closed loop obstruction. Right. So hernias which have a narrow neck might allow a loop of bowel to slip through, and the bowel then gets entrapped and caught. These patients present with intestinal obstruction in surgical wards. Yes, because especially in these two, they have a fairly narrow neck. The other thing that you fairly commonly will come across is this thing called adhesive obstruction. Adhesive obstruction is one of the commonest or common causes of intestinal obstruction you will see in emergency or surgical wards. And basically what it means is these are patients who have had usually have had previous abdominal surgery. And one of the common surgical procedures or the commonest surgical procedure responsible for adhesive obstruction is an appendicectomy. However, nowadays with laparoscopic surgery and laparoscopic appendicectomies, the incidence of this is less, but it's still there. So patients can have had a laparotomy for some perforation or whatever previous procedure. What happens is after surgery, during the healing process, fibrinous adhesions then form fibrous adhesions between loops of bowel. And once in a way, what happens is these loops of bowel twist upon themselves and can get kinked. It's usually small bowel obstruction, can be ileal or jejunal ileal obstruction. And they will have come with pain, vomiting, but usually these patients do not require surgery. You just need to rest the gut, give them some fluids, pain relief, keep them off anything orally for a while, and it settles spontaneously and they go home. Having said that, some of them can come repeatedly. Sometimes they may come for the first time several years after the primary operation, and then they don't have it ever again. But it's something that you might see in patients who come to the casualty ward. So it's very important to find out whether patients have had previous abdominal surgery or procedures or inflammatory conditions, because they can have adhesions that cause small bowel obstruction. Okay, so that's about it. So in summary, you should know that intestinal obstruction is, as I told you, primarily a clinical diagnosis with radiological assistance or adjuncts. What we really want to know when somebody comes is what is the site of obstruction and what is causing obstruction. Remember, fluid and electrolyte depletion is a major problem or consequence of intestinal obstruction, and we need to remember the hidden losses like sequestration in the small bowel. We also need to be aware of complications, especially bowel ischemia and bowel ischemia leading to gangrene and perforation. So we need to pick this up early to prevent sometimes death and also morbidity in patients. And before we undertake surgery, we need to decompress the bowel as much as possible, nasogastric tubes, resuscitate these patients with fluids, electrolytes, correct any acid-base imbalance as much as possible, and then if they don't resolve, take them for surgery. Okay, so that those are the basics of intestinal obstruction. Are there any questions anybody would like to ask? Any doubts, any questions about any of the slides? Yes, is paralytic ileus associated with hypokalemia? Yes, the answer to that is yes. One of the conditions that predisposes to paralytic ileus is hypokalemia. So if you have a low potassium, it will or it can contribute significantly to paralytic ileus. Yes, the answer to that is yes. Okay, nothing else? Okay, guys. We'll stop then. Thanks.
Thank you.